Hello everyone. So today we will get to know about the various drugs used for the treatment for bronchial asthma. So first we should know that what is bronchial asthma. Basically it is hyperresponsiveness of tracheobronchial smooth muscle which leads to the narrowing of the air tubes. The various symptoms of bronchial asthma are dyspnea. You will feel discomfort in the breathing, then wheezing and then cough. Asthma is basically of two types, extrinsic asthma and intrinsic asthma. In the extrinsic asthma, it is the allergic one, means it is triggered by external allergens or the exposures. Example, dust mites, pollen, molds, food and drugs. And it is mediated by IgE immunoglobulin. And the intrinsic asthma is non-allergic. Example, respiratory infection, cold air, exercise, stress, smoke, strong odors, aspirin, NSAIDs, and it is non-mediated by IgE antibody. The various mediators which are released immediately after triggering asthma are histamine, protease, enzymes, TNF, and within minutes release of phospholipids like prostaglandins, leukotrienes, PAF, and within hours activation of genes followed by protein synthesis that are interleukins and TNF, tumor necrosis factor alpha. Release of these inflammatory mediators cause smooth muscle of bronchus constriction and then bronchial smooth muscle hypertrophy is occurs. We should know what is COPD. COPD is the inflammation which is dominated by the neutrophils, macrophages and the cytotoxic lymphocytes, and it is progressive emphysema, means alveolar destruction. First your alveoli looks like this and then it will become like a circle if it is damaged, and then loss of bronchial elasticity, then closure of the smaller air tube. COPD is related to the smoking. When a person smokes very much, then he may have chances to get this disease, to get this condition. And increasing part of airway obstruction is irreversible. This condition is irreversible. Now let's study about the various sympathomimetic drugs which are used in the treatment of bronchial asthma. So the adrenergic drugs, what they actually do, they do bronchodilation. So in asthma you will feel bronchoconstriction due to the immediate release and adrenergic drugs helps to relieve that bronchoconstriction. They do bronchodilation by the beta 2 receptor stimulation. By the activation of beta 2 receptor, there is increased CAMP formation in the bronchial smooth muscles, and then the relaxation will be occurred. Increased CAMP in the mast cell will decrease mediator release, and by decreasing this mediator release you will not feel any bronchoconstriction again. Adrenergic drugs used in the treatment of reversible airway obstruction, means in asthma you can use them. And the beta 2 agonists are the fastest acting bronchodilators. Adrenaline, which is beta 1, beta 2 plus alpha receptor agonist. Isoprenaline is beta 1 plus beta 2 agonist, and they both are effective bronchodilators and selective beta 2 agonist. Then comes our drugs. First is salbutamol, which we also known as albuterol, and it is a selective beta 2 agonist. It is given by pressurized meter dose inhaler, and it produces bronchodilation in 5 minutes and action lasts 2 to 4 hours. And salbutamol is used to abort and terminate attacks. The various side effects are muscle tremors. Muscle tremors are the principal side effect, and then hypokalemia patient can face. Then single enantiomer preparation of R negative salbutamol is have less side effects. Then comes our next drug, terbutaline. It is inhaled salbutamol and terbutaline used for the quick reversal of bronchospasm. Regular use can worsen hyperactivity and down regulates bronchial beta 2 receptor. Patient required regular medicine should be treated with inhaled steroids with or without long acting beta 2 agonist, example salmeterol. Short acting beta 2 agonist gives symptomatic relief of wheezing. Next drug is balmbutyrol, which is biscarbamate ester prodrug of terbutaline. It is indicated in the nocturnal and the chronic asthma as a single evening dose 10 to 20 mg. Then comes our salmeterol drug, which is first long acting selective beta 2 agonist, and it is used for the maintenance therapy and the nocturnal asthma, and it is more beta 2 selective than salbutamol and more lipophilic than salbutamol. Then comes our indacaterol, odo, ol, olodaterol and vilanterol. These are the new ultra long acting selecting beta 2 agonist, and they are used in the maintenance therapy of COPD. Inhalational in powdered form are indacaterol and vilanterol, and the solution form is olodaterol. Then comes our 4-metrol, which is long acting selective beta 2 agonist, and it acts for 12 hours when inhaled, used on the regular morning evening schedule for round the clock bronchodilation. Ephedrine is oral alpha plus beta 1 plus beta 2 action sympathomimetic, and it is not preferred now. Here is the classification of the various drugs which are used in the treatment of bronchial asthma, in which the first class is bronchodilators, which is further classified in 3 types, that are beta 2 sympathomimetics, methylxanthines and anticholinergics. In the beta 2 sympathomimetics, the drugs are salbutamol, terbutaline, bambuterol, salmeterol and 4-metrol. The next class is methylxanthines, in which theophylline, aminophylline choline, theophylline hydroxy, and then anticholinergics, in which ipratropium bromide and tiotropium bromide comes. Then comes our mast cell stabilizers, in which sodium chromoglycate and then butotefen, which is an antihistaminic drug, but it have chromoglycate like action also. Then comes our corticosteroids, in which systemic corticosteroids and inhalational corticosteroids are available, and in the systemic ones hydrocortisone, prednisolone and other glucocorticoids occurs, and in the inhalational ones baclomethasone dipropionate, budesonide, fluticasone propionate, flunisolide and cyclosinide comes. And then comes our anti-IgE antibody, which is omalizumab. So as we already covered the beta 2 sympathomimetics, so now we will start with methylxanthines, which are used in asthma but restricted in COPD, and it is naturally occurring in the methylated xanthine alkaloids like caffeine, theophylline and theobromine. So when the methyl group is attached at first, third and seventh position of the xanthine moiety, then it is known as caffeine. When it is attached at first and third position, then it is theophylline, and when it is attached at third and seventh position, then it is known as theobromine. And theobromine have no therapeutic activity. It is the basic difference or comparative action of the caffeine and theophylline, which you can see and note down, but let's discuss in the other form. So let's start with the basic pharmacological actions of caffeine and theophylline. As we already know, the theobromine have no therapeutic activity. So let's start with the central nervous system. So the caffeine 150 to 250 mg produces sense of well-being, alertness, beats boredom, allays fatigue, thinking becomes clearer, and caffeine stimulates more than theophylline. In the higher doses, it causes nervousness, restlessness, panic, insomnia, excitement. Theophylline is more toxic than caffeine. Let's start with the cardiovascular system. So caffeine and theophylline both increases myocardial contractions, increases heart rate by cardiac action and decreases by the vagal action. So they both have both actions, like stimulating actions also and the vagal actions also. Tachycardia is more common with the theophylline. Caffeine decreases heart rate. More than 9 cups of coffee per day increases arrhythmia incidences. Theophylline dilates blood vessels. Caffeine cranial vessels constrictions. That's why it is used in migraine. So as we already know that when we suffer from migraine, our blood vessel dilates, so we need to constrict them. So for the constriction of the cranial vessels, we can use caffeine. On BP on the vasomotor and the control cardiac center stimulation. It raises BP, and by the vagal action it lowers the BP. In the smooth muscles, all the smooth muscle relax by the action of caffeine and theophylline, but theophylline is more potent bronchodilator than the caffeine. The vital capacity increased. In the kidney, it acts by inhibiting tubular reabsorption of sodium and water, as well as increased renal blood flow and glomerular filtration rate. And in the skeletal muscles, caffeine at very high doses increases release of calcium ions from the sarcoplasmic reticulum, and it increases contractile power. In the stomach, it increases the acid pepsin secretion. Methylxanthines are gastric irritants also, so the theophylline produces more effect than the caffeine. In the metabolism, it increases the basal metabolic rate. And in the mast cell and the inflammatory cells, theophylline decreases the release of histamines and other cytokines from the mast cells and activated inflammatory cells. The various mechanism of action of methylxanthines are: it increases the release of calcium ions from sarcoplasmic reticulum, especially in the skeletal and the cardiac muscles. We know that ATP or GTP that is converted to CAMP or CGMP by the help of adenyl cyclase and the guanyl cyclase. Then it is converted to 5-AMP or 5-CGMP by the help of phosphodiesterase. Now, what theophylline actually does, it inhibits the phosphodiesterase enzyme, by which the CMP or the CGMP concentration will be increased. The concentration of cyclonucleotides is basically increased, which leads to the bronchodilation, cardiac stimulation, and the vasodilation. And the mediator release is also inhibited by the increased CMP concentration levels. It rises in the bronchial, cardiac, and the vascular smooth muscles and in the inflammatory cells. Roflumilast have anti-inflammatory actions in the lungs, so it is approved by US FDA for symptomatic treatment of COPD, but it is not used for bronchial asthma. The adverse effect of roflumilast are diarrhea, weight loss. Blockade of adenosine receptor, it is the third mechanism of action, and the adverse effects are: theophylline have narrow margin of safety, so you need to monitor that drug. Various uses of methylxanthines are in the bronchial asthma and the COPD. Theophylline is more useful in COPD than the asthma. And apnea in the premature infant, we can use methylxanthines. Then comes our anticholinergics, in which two drugs are there: ipratropium bromide and the tiotropium bromide. The ipratropium bromide is the short acting one and the tiotropium bromide is the long acting one. So what they actually does, they block M3 receptors. By blocking this M3 receptors, they cause bronchodilation. And the sol-butamol mainly relaxes bronchiolar smooth muscles, and the ipratropium bromide blocks bronchoconstriction mainly in the larger airways. Ipratropium bromide have the short action, means 4 to 6 hours its action will be last, and it is used in the inhalation form. And then the tiotropium bromide, it is a long acting one drug and it works for 24 hours. Then comes our inhaled anticholinergics. They are the bronchodilators of choice in the COPD. And then glycopyrronium bromide, it is another longer acting quaternary anticholinergic drug. Then comes our leukotriene antagonist, in which two drugs are main, montelukast and the gefelukast. What they actually do, they block the cystenyl leukotriene receptor and they block it competitively, so they are the antagonist of this mediator. So it is released, these mediators are released when there is inflammation in the lungs. So montelukast and gefelukast blocks this receptor and it causes bronchodilation, reduced sputum eosinophil count, suppression of bronchial inflammation. Cystenyl leukotriene antagonist, are effective in the aspirin-induced asthma and the exercise-induced asthma, but the few cases of Churg-Strauss syndrome reported. Then comes our gelatin drug, which is a 5-LOX inhibitor, and it blocks LTC4 and D4 as well as it inhibits LTB4 synthesis also, but it have hepatotoxic potential. That's the reason why it is withdrawn from the market. And then comes our mast cell stabilizers, in which sodium chromoglycate drug, we also know it by the name cromolyn sodium, so it inhibits the degranulation of the mast cells. Then comes our ketotifen, which is an antihistaminic drug. Let's start with the corticosteroids. What they actually does, they inhibit the inflammatory cytokine productions and the eosinophilic lymphocytic infiltration of the lungs. So by doing this, they decreases the bronchial hyperreactivity, mucosal edema, and the suppress inflammatory response to antigen antibody reactions or to the other trigger stimuli. Then comes our systemic corticosteroid therapy. As we already know, it is of two types, systemic and the inhaled corticosteroids. So in the systemic one, first come our severe chronic asthma, which is not controlled by the bronchodilators or the inhaled corticosteroids. So start with prednisolone 20 to 60 mg daily. Dose reduction after 1 to 2 weeks. You should not be tapered this corticosteroid therapy immediately because its withdrawal effects are very dangerous. So then you need to shift to the inhaled corticosteroids. Patients required long-term glucocorticoid therapy should try the alternative treatment with the immunosuppressants like methotrexate in the low doses, and the cyclosporin has been also tried. Then comes our status asthmatics and the acute asthma exacerbations. So asthma attacks not responding to the bronchodilators. If a person is not responding to the bronchodilators, then what you need to do, you need to start with the high doses of rapidly acting IV glucocorticoid. You need to give glucocorticoids intravenously so that it can act immediately. Then you need to shift to the oral therapy for 5 to 7 days. Then comes our inhaled corticosteroids, which have mainly high topical and low systemic activity, means it is going to the blood in very low quantity and it is acting topically only. So the drugs which comes in the inhaled corticosteroids are the baclomethasone, budesonide, fluticasone, and dipropionate, cyclosonide. Inhaled corticosteroids are the step 1 for all asthma patients. Inhaled corticosteroids suppress bronchial inflammations. Patients who are to be switched over from oral steroids should receive inhaled corticosteroids. Means when you are taking oral steroids, they are definitely going into your systemic circulation. So when you are shifting, then you need to shift it from oral to inhaled one first. In addition, for 1 to 2 weeks. So after stopping the oral therapy for 1 to 2 weeks, you need to continue this inhaled corticosteroid therapy before oral steroid is tapered. Otherwise, steroid withdrawal may manifest. So what you can face are the precipitation of asthma attacks फिर से आने लगेंगे, muscular pain, depression, hypotension, and then oral candidiasis. So it is an adverse effect which is faced by the inhaled corticosteroid therapy. So it can be treated by the nystatin and clotrimazole drug. You should know that thing. Then the inhaled steroids are safe during pregnancy. This is very important point when somebody is pregnant and they need the steroid therapy due to the asthmatic attacks. So the inhaled steroids are very safe during the pregnancy. Then comes our baclomethasone dipropionate. It is taken in intranasal spray 50 microgram in each nostril, which is effective in perennial rhinitis. Then comes our budesonide drug, which is a non-halogenated glucocorticoid, 200 to 400 microgram per day by intranasal spray for prophylaxis and the treatment of seasonal and perennial allergic or vasomotor rhinitis and the nasal polyposis also. Then comes our fluticasone propionate, which have high potency and the double of baclomethasone. Flunisolide, it is used for the seasonal and perennial rhinitis. Then comes our cyclosonide drug, which is a prodrug, and it is cleaved by the enzyme esterases, and the active moiety is released in the bronchial epithelium. Then comes our anti-IgE antibody, which is omalizumab, humanized monoclonal antibody against IgE, and it is taken subcutaneously.